Let me change the screensaver. Okay, so today we'll be doing orthopedics, which is a little bit difficult for me because personally I need to finish 90 pages and I need to do it very, very fast. So I've come to the realization that I can stream for max to max 1 hour. So the way I think is wherever possible, if I'm going to have some fun or some shit, I'll stream for 1 hour and then I'll have fun for like 1 hour. That's the way I think I can live my life. So if you guys see me a lot of times, if you see me streaming a lot of times from now on, then you can assume that's my lifestyle. I just keep on I stream for an hour, then another hour I play video games, or I see videos, or I work out or do some shit, and after that again I'll stream for another hour. How much ever time I want break, I'll take the break, but streaming I'll do only for 1 hour. So let's move on. We have Orthopedics Pakka Pass. This is the ideal book, honestly, to just finish off all orthopedics. Entirety of orthopedics will be done in this one book. It's having 100 pages almost. So if you go back to my metric, I can teach around 20 pages in 1 hour. I will need to do this for 8 hours, which is okay. So this first one, I think I'll just stream for like 15 minutes. I have to eat dinner because it's like 9:17 right now, unfortunately. So okay, let's start off with orthopedic trauma. So orthopedic trauma, we have first of all classification of fracture. A fracture is a break in the continuity of the bone. On the basis of etiology, you have traumatic and pathological fracture, and you have stress fracture. So traumatic fracture are those sustained due to trauma. Example, those caused by fall, road traffic accident, fight, etc. Pathological fractures are those fractures which has been made weak by some underlying disease. So there is minimal force which may cause such a fracture. Increased chances of non-unionism and fracture through a bone is weakened by metastasis. So if you have a fracture that is through a bone, it will be weakened by metastasis. So stress fracture is sustained due to chronic repetitive injuries, like stress which causes a break in the bony trabecule. It is presenting only as pain and may not be visible on X-ray also. Only pain it will be there. Chronic repetitive injury causes a break in the bony trabecule. Okay, pathological fracture, minimal force may cause a fracture. Increased chance of non-union, fracture through a bone, weakened by metastasis. Example, fall, road traffic accident, stress and all. Chronic repetitive injury. Okay, on the basis of displacements, you have undisplaced fracture and displaced fracture. So factors responsible for displacement are fracturing force, muscle pull on the fragments, and gravity. So you have types, you have shifts. It can be completely shifted, it can be angulated, and it can be rotated. There are the images also here. Then on the basis of complexity of treatment, simple fracture in 2 pieces, easy to treat. Example, transverse fracture of the humerus. Complex fracture in multiple pieces, difficult to treat, like comminuted fracture of tibia. On the basis of relationship with external environment, you have closed fracture and you have open fracture or compound fracture. Closed is not communicating with external environment, that is the overlying skin and soft tissues are intact. You have to write. Fracture with break in overlying skin and tissue is called open or compound fracture. Fractures communicate with external environment and they are prone to infection, and they are of 2 types. You have internally open from within and externally open from outside. So internally open, you have sharp fracture end pierces the skin from within. The sharp fracture end pierces the skin from within. That is internally open. Then externally open is objects are there from external environment which causes the fracture, which lacerates the skin and soft tissue over the bone. So on the basis of quantum of force causing, you have high velocity injury and low velocity injury. High velocity is sustained due to severe trauma force. There is severe soft tissue injury, periosteal and muscle injury will be there. Extensive devascularization of the fracture ends, and fracture are often unstable and slow to heal. Low velocity injury is fracture due to mild trauma as in fall. Minimally associated soft tissue injury will be there, and they heal predictably. They are more predictable, whereas the other things are unpredictable. And On the basis of pattern, you have transverse fracture, oblique fracture, spiral fracture, comminuted fracture, and segmental fracture. There are all these images which provides a very clear idea. Okay, so going on. So transverse fracture plane perpendicular to the long axis of the bone, perpendicular to the long axis, caused by tapping or bending force. Oblique is the line, fracture line is oblique. Spiral is the line runs spirally in more than one place. It will run very much spirally. It will go up and down and stuff like that. Then, and it is caused by primarily a twisting force. Okay, comminuted is fracture with multiple fragments. It is caused by crushing or compression force. There are two fractures in one bone, but it will be at two different levels. Then it is segmental. Pathological fracture is fracture through a bone which has been made weak by some underlying cause. Okay, so minimal force causing such a fracture will may be there. There is increased chance of non-union, and etiologically it is having two etiology. It is having hereditary etiology or it can be acquired etiology. In hereditary, you have osteogenesis imperfecta, dyschondroplasia, and osteoporosis. In acquired, you may have osteoporosis, osteomalacia, rickets, scurvy, osteomyelitis, primary bone neoplasm, and in the primary bone neoplasm, it may be benign tumor or malignant tumor, and you have also have secondary bone neoplasm. So in primary benign, you have giant cell tumor, enchondroma. In malignant, you have osteosarcoma, Ewing's tumor. Secondary bone neoplasms, in male it can be lung, prostate, and kidney. In female it may be breast, lung, and cervix. Lung, prostate, and kidney is more common in male. In female, breast carcinoma, lung carcinoma, cervical carcinoma is more common. So osteogenesis imperfecta, dyschondroplasia, in improper development of bone, osteopetrosis, brittle bones, marble bones, it is called as. Only as this is, I think we will talk about these in the future. Osteoporosis, of course, acquired. Osteomalacia is also acquired. Rickets, scurvy, osteomyelitis, primary bone tumors. Okay, so treatment, you detect the underlying cause of the fracture, make an assessment, capacity of fracture to unite based on nature of underlying disease. Okay, so anatomy of bone and fracture healing. You have to first find out the age of the patient. Fracture unit faster in children and in younger children. Type of bone you have to see. Flat and cancellous bones unite faster. Trabecular and cortical bones unite slower. Okay, so you also have a pattern of fracture. Spiral is faster than oblique, which is faster than transverse. Because of spiral, it's gluing more faster. Oblique also is a little bit better hold. Transverse, it will slip very easily. You can remember it like that, but it may not be exact reason of it. Then disturbed pathoanatomy may also be there. If there is soft tissue interposition between fragments prevents callus from bridging the fragments, and ischemic fracture in the ends. So type of reduction, good opposition of fracture results in faster union. At least half of them, I don't know what they are saying. Okay, good position, faster union. That is the reason. There is better opposition in spiral, oblique, and all. Then in children, a fracture may unite even if the bones are only side to side in contact because of bayonet reduction. There is bayonet reduction in children. Then immobilization. Immobilization is not necessary in all fracture. Like in ribs and scapula and all, you don't need to immobilize. However, some fracture requires strict immobilization, like fracture of neck of femur. Then open fracture, delayed union and non-union chances are more. And compression at the fracture site. You have compression which enhances the rate of union in calcaneus bone. In corticular bone, compression at the site results in primary bone healing. Okay, so stages of bone healing, you have stage of hematoma, less than 7 days. Fracture and necrosis occur. Sensitization of precursor cells occurs. Then you have granulation tissue up to 2 to 3 weeks. Proliferation and differentiation occur. Daughter of cells, proliferation and differentiation of daughter cells into vessels, fibroblasts, osteoblasts, etc. But the fracture is still mobile. There is only granulation, and granulation, of course, there is proliferation. Then you have stage of callus, which is 4 to 12 weeks. Mineralization of granular tissue occurs. Callus, radiologically, it will be visible. Fracture clinically united, and it will be no more mobile. The fracture will not be mobile at the stage of callus, and it is radiologically visible. Then stage of remodeling. Lamellar bone formation by multicellular unit based on remodeling of callus. So outline of callus becomes dense and it becomes sharply defined. There will be remodeling. Lamellar formation by multicellular unit based on remodeling of callus. Laminar formation will be there based on multicellular unit based on remodeling of callus. Outline of callus becomes dense and sharply defined. Outline will be sharply defined. Then this lasts for 1 to 2 years. Then we move on. We have stage of modeling. Modeling is an industrial and periosteal surface. Modeling of industrial and periosteal surface so that fracture site becomes indistinguishable from the parent. Whereas here you can see it is sharply demarcated, dense and sharply demarcated. Here it will become normal. It will happen over many years. Okay. So treatment of fracture, general principle, you provide plaster of Paris, which is gypsum salt. Hemihydrate calcium phosphate, which becomes .2H2O on wetting. This conversion is an exothermic reaction and is irreversible. POP sets in and gives shape on drying. So you have various casts over there, but I think you don't really need to remember a lot of them. Just remember Spica will be there, Collis cast will be there, U slab is important. That's more than enough. Just write you have several casts, example U slab, Collis cast and Spica. So fundamental principle for applying a plaster cast is to immobilize the joint above and below the fracture. Immobilize joint in a functional position and pair the limb adequately, especially on bony prominences. Just a second. I think I'm going to end the stream right now. I'll just finish off. Okay, I'll just finish off just a second. After care of the plaster, notice any crack in the plaster, avoid wetting the plaster and exercise the muscle within the plaster. Complications may be gangrene, unrelenting phase, pain, swelling over the fingers, inability to move the finger, hyperexia and bluish discoloration of the digits due to impairment of circulation due to tight cast. Then you have pressure sores and due to inadequate padding, inner surface of the cast or foreign bodies in the plaster. All of irregularity of the inner surface of the cast and foreign bodies in the plaster will lead to the formation of plaster sore. Pain will be there, fretfulness will be there, anxiety basically. Disturbed sleep will be there, recurrence of swelling over toes or fingers is noticed, and there will be low grade fever and patch of blood soaking over the cast. There will be blood or soakage over the cast because of formation of ulcer and bleeding and stuff like that. So, okay, so general plan for treatment of fracture. You have a fracture, it will either be undisplaced, it will be displaced maybe. If it is undisplaced, you have to immobilize and give physiotherapy. If it is displaced, you have primary open reduction and close reduction. And if it is open reduction, you have to do it reduction, internal fixation you have to do, and physiotherapy you can give. Close reduction you can manipulate and provide traction. It can be in acceptable position or unacceptable position. If it is in acceptable position, you immobilize and provide physiotherapy. If it is in unacceptable position, you do open reduction and internal fixation and physiotherapy. So open reduction straight away is required for some fracture. Immediately you need to do open reduction in some type of fractures. Complications, you have infection of bone, inability to use traditional methods, problem with union, non-union and malunion. Those are the complications of the fracture. And okay, that's all for this stream. I'm going to stop now and yeah, we were at what do you call this? Fracture of... No, we are not here. We were somewhere else. We are here. Splints and traction. So okay, I'll finish. I finished like a big chunk of it before going to sleep because I don't know, the way I think is like, if you just in cases where I have to stay, if I just feel that there is someone there who will listen to me, then I tend to teach a little bit better. I feel like there's an obligation over there, and I'm trying to use that as a road mark of sort to just study. So moving on, we have splints and tractions. So splints can be adhesive strap which is applied on skin, and traction is applied. So strap is adhesive strap is applied on skin and traction is applied. That is skin traction. Adhesive strap, skin, deep fascia, intermittent septa, and bone. Those are the orders. It is transmitted from skin in that order. Okay. So skeletal traction is applied directly on the bone by a K-wire or Steinmann through the bone. Directly. This is a Steinmann pin, and this is a leucoplast. Steinmann K-wire is there. So skin traction you require moderate to okay. So there have been skin traction, where is it required? Skeletal traction, where is it required? And they've been explaining here. Skin traction if mild to moderate force, but if it's moderate to severe, you need to use skeletal traction. Age in children, it is skin traction is enough. In adults, you have to give skeletal traction. It is supplied with adhesive plaster in children and Steinmann's pin and K-wire in adult. It is applied on the skin, of course, and this is through the bone, mostly below the knee you apply, and here mostly it's above the tibial pin. And weight, it is permits around 3 to 4 kg, whereas skeletal traction permits up to 20 kg. Used for shorter duration is the skin traction, and longer duration is the skeletal traction. Then Thomas knee bed splint, which is a Thomas splint, devised by H.O. Thomas initially for immobilization for tuberculosis of the knee. If you have tuberculosis of the knee and you need immobilization, you do Thomas knee bent split. So parts, you have a ring and two sidebars. Joint distally. Distally, these two joint sidebars are joint. Ring is at an angle of 120 degrees to the inner bar, and outer bar has a curvature near its junction with the ring to accommodate the greater trochlear. So you find a good ring size and length of splint, and ring size through the thigh circumference at the highest point of groin plus 2 inches. That is the ring size. And then highest point of groin plus 2 inches. It doesn't really make sense. Okay, so it also has a place for the to accommodate greater trochanter. Length is the distance from the highest point on the medial side of the groin to the heel plus 6 cm. Plus 6 inches. That's more like 7.33. That's more like 8 centimeters. 8 centimeters, yeah. Okay, Thomas ring splint is introduced around the limb. Leg and thigh are supported by the slings tied over the sidebar. Okay, you put it, this is bigger than 2 inches circumference is more than 2 inches. So you just put it and you put slings and you tie it over the sidebars. So recent advances, you have splinting, which is done to keep an injured bone from moving and protect it from any further damage. That is splinting. So methods, you have intramedullary splinting, which is fixation of a fracture of long bone. Example, fracture of shaft of femur. Then you have long hollow rod called nail is inserted in the medullary cavity of the long bone. Extramedullary splintering, you apply a neutralizing plate on the surface of the bone. This is the splinting with neutralizing plate. This is intramedullary splinting. Then outside the body, you have the pins are inserted through the skin into the bone and held outside with clamps and rod, which are external fixators. This is external fixators used to hold fragments of an open fracture. We also have buttressing plating. Okay, so combination of compression and splinting used in a fracture of shaft of femur. You have to give both the combination of compression also should be given and splinting also should be done. So stabilized by using interfragmentary screws across the fracture and neutralizing plate to add to fixation. So you use a combination of compression screws and a neutralizing plate used for spiral fracture in this example. Then you have fracture disease, which is according to Association for Osteosynthesis and Association for Study of Internal Fixation. It is due to early immobilization, the achieving stable fracture by interfragmentary compression, splinting and combination of splinting and compression. That is how you achieve fixation of fracture. Then prevents disadvantage of immobilization, which is termed as fracture disease. So there is no disadvantages of immobilization. Then you have joint stiffness and muscle wasting is seen. So approaches to a patient with limb injury, you have due to fracture on an outstretched hand, you will have scaphoid fracture, distal radius Colles and Smith fracture. You have radial or ulnar styloid fracture. Radial head fracture will be there. Distal radio-ulnar joint fracture is there. Scapho-unate tear is there. Hook of Hammett is there. Clavicular fracture is there. Supracondylar fracture of the humerus is there, and triangular fibrocartilage complex TFCC injury and shoulder joint injury is there. Then you have complications of fracture. You have immediate complications. You have systemic, you have hypovolemic shock. Local, you have injury to major muscles, major vessels, muscles, tendons, joints, viscera. You can have injury and hypovolemic shock. Early complication, you have hypovolemic shock, acute respiratory distress syndrome, fat embolism syndrome, DVT and pulmonary embolism, aseptic traumatic fever, septicemia in open fracture, and Crus syndrome. So you can remember it as like early hypovolemic shock is there, obviously. ARD is respiratory distress because of fat embolism syndrome, and DVT also will be there. Pulmonary embolism will lead to ARDS. Traumatic fever is there if there is a lot of traumatic fever. Septicemia in open fracture, you will be having septicemia because of spread of infection and stuff like that. And Crus syndrome is because you provide a lot of corticosteroids, maybe something like that. Okay. Immediate hypovolemic shock, major vessels, muscles, tendons, joints, viscera. All of them you can have injury. So local, you can have infection and you have compartment syndrome. Late complications, you have imperfect union of the fracture and others. So imperfect union, you have delayed union, non-union, malunion, and cross union. All of these can occur. Others, you have avascular necrosis, shortening, joint stiffness, pseudex dystrophy, which is reflex sympathetic dystrophy. Osteomyelitis you can have, ischemic contracture you can have, myositis you can have, myositis ossificans you can have, and osteoarthritis you can have. All of these you can have. Others, late complication, imperfect union of the fracture. Then you have reflex sympathetic dystrophy, which is Seudex dystrophy. It is a vague, painful condition observed as a sequel of trauma. So you can have in Seudex dystrophy, you can have pain, hyperesthesia, tenderness, swelling, skin red, shiny and warm. X-ray, you can see spotting, spotty rarefaction. Okay, spotty rarefaction. So treatment, you have physiotherapy and beta blockers therapy, which you can provide, which can become beta blocker therapy, which is sympathetic, leading to sympathetic, and then after that you can give sympathetic block. Okay, it is due to sequel of trauma. Pain will be there, abnormal sensation will be there, tenderness will be there, swelling will be there, skin will be red, shiny and warm. Right. Okay, I had to just check something. Sorry. Delayed and non-union. Delayed union means there will be delay in the union. Marriage होने में time लेता है. Failure to reach the bone union by 6 months. Non-union is failure of fusion, bone fusion. Okay, completely failure of bone fusion. By 6 months is delayed. Non-union is complete failure. So causes, age-related causes, age in common in old age. Associated systemic illness, you can have malignancy and osteomalacia. Malignancy may be there, osteomalacia will be there, which will cause the delayed union or non-union. So causes related to fracture, you can have distraction at the fracture site. Muscle pulling the fragments can occur, gravity also may be there. Soft tissue interposition can be there. Bone loss may be there at the time of the fracture. Infection can be there from an open fracture. Damage to the blood supply to the fracture fragments may be there, and pathological fracture can also be there. So related to the fracture, distraction at this fracture site, muscle may pull the ligament fragments, which may lead to fracture patella and fracture olecranon. Gravity may again distract the ligaments, which may lead to fracture of the shaft of the humerus. Soft tissue interposition can occur, which can lead to fracture of shaft of femur, shaft of humerus, and fracture of medial malleolus, which is abduction type. Then bone loss can occur at the time of fracture, which can be fracture tibia open type, fracture ulna open type. Bone loss at the type of fracture. Tibia and ulna is commonly you can have open type. If they are there, then some small pieces of bone and all will run away. Soft tissue interposition, shaft of femur, humerus, and medial malleolus. Abduction type fracture. Okay. Then you can have infection from an open fracture, most commonly tibia, because tibia most commonly it's open fracture. Damage to the blood supply from fracture fragments, it can be due to fracture of neck of femur. It can be due to fracture of lower third of the tibia, and pathological fracture, fracture of shaft of the femur and fracture of humerus. Neck of the femur is a very well-known case of avascular necrosis. So damage to blood supply will lead to avascular necrosis. Lower third of the tibia is also having poor vascular supply, and therefore damage fracture to the lower third of tibia leads to damaged blood supply. Then causes related to treatment, inadequate reduction you can have. Fracture of shafts of long bone, inadequate immobilization may be seen, where you have in fractures of shaft of long bone again, and fractures of neck of femur. Distraction during treatment can be there in fracture of shaft of femur. Then clinical findings, you have persistent pain on stressing the fracture, mobility in non-union may be there, and increased deformity at this fracture site in non-union. So diagnosis, you can have chest x-rays. It can be delayed union where the fracture line is visible. Inadequately, the callus may be breaching the fracture site. Non-union may be there where the fracture line is visible, and fracture may be rounded, smooth, and sclerotic. You have delayed union and non-union. As far as treatment goes, delayed union leading to delayed union, you may require bone grafting with or without internal fixation. Non-union, you require open reduction, internal fixation, and bone grafting. All three needs to be done. Delayed union, bone grafting with or without internal fixation. Non-union, you require open reduction. Open, you have to remember open and reduce it. You require internal fixation and you need a bone grafting. You have Eliziero's method, which is external fixation in the management of non-unions. Okay, so malunion. Malunion is a condition where the fracture does not unite in proper position. It can be caused by improper treatment, unchecked muscle pull, fracture of the clavicle, excessive communication, which is Colles fracture. Again, malunion occurs due to improper treatment, excessive muscle pull, fracture of clavicle, excessive communication, which is Colles fracture. This is delayed and non-union. Malunion, the fracture does not unite in proper position, caused by improper treatment, unchecked muscle pull, and excessive comminution. The Colles fracture. You also have common sites of fracture. It is fracture at the ends of bone, always often it malunite. It can be supracondylar fracture of femur and Colles fracture. It can lead to deformities, shortening of limb, limitation of movements. Then treatment, you provide osteochlasis, which is refracturing the bone. Under general anesthesia, you refracture the bone. It is recreated, angulation is corrected, and limb is immobilized in plaster. Then you can redo the fracture surgically. Fracture site is exposed, malunion is corrected, and fracture is fixed internally with suitable implants. Then you can also do corrective osteotomy, which is deformity is corrected by osteotomy at the site away from the fracture. Osteotomy can be done away from the structure, whereas redoing it is at this fracture. Osteoclasis is refracturing the bone. So corrective osteotomy, deformity corrected by osteotomy at a site away from fracture. Example, supramalleolar corrective osteotomy for malunion of distal third of the fracture. So above the malleolus, you can correct the osteotomy even though the malunion is distal third of the tibial fracture. So you can also have excision of the protruding bone spiking through under the skin is excised. So the bone is spiking, protruding under the skin, it is excised. Example, malunion of fracture of shaft of tibia, clavicle, etc. Malunion of fracture of shaft of tibia. Next, we move on to avascular necrosis. Avascularity of a bone is jeopardized following fracture resulting in necrosis. So commonly it can be FST, femur, proximal part of scaphoid, and body of talus. Scaphoid and talus, then head of femur. Those three are the only three which may be there. Fracture of neck of femur, posterior dislocation of hip may lead to head of femur fracture. Fracture through the wrist of the scaphoid can lead to proximal pole of scaphoid to be avascular, and fracture through the neck of talus will lead to body of talus. So consequences, you can have bone deformation, secondary osteoarthritis, joint movement will be limited. Okay, bone deformation, secondary osteoarthritis can occur, bone can be deformed, and joint movement may be limited. Then diagnosis, you can do chest X-ray. So you'll find sclerosis, sclerosis of necrotic area. Sclerosis of necrotic area, deformity of the bone. Of course, bone deformity is a complication. Osteoarthritis, you will find diminished joint space, diminished osteophytes leading to lipping of bone from the margin. I don't know how it will appear, but yeah, okay. Lipping of bone you can see from the margin. Then you can also do a bone scan. You'll find necrotic area visible as a cold area. Then treatment, you have early energetic reduction of susceptible fracture and dislocation. You can have early energetic reduction of fracture, susceptible fracture and dislocations. Delay weight bearing on necrotic bone until it is revascularized, which may be 6 to 8 months from the bone to revascularize. So revascularization procedure, you have a vascularized bone graft of greater trochanter in the femur neck fracture. So you can also do a orthodesis, which is total joint replacement with 2 hours. In case of pain due to secondary osteoarthritis, you can do a total joint replacement for osteoarthritis. Okay, so moving on, you have myositis ossificans. Myositis ossificans is post-traumatic ossification. Ossification of hematoma around a joint leading to formation of a mass of bone restricting the joint movements. So it is caused by severe injury to the joint. Capsule and periosteum stippling from the bones. Children periosteal body is loosely attached to the bones. So if you provide massage following trauma, it will aggravate the myositis. So consequences, of course, joint stiffness and extra-articular ankylosis can be seen. So radiologically, you have acute myositis and mature myositis. Acute is margins of the bones are fluffy, whereas in mature myositis, bone appears in the trabecule with well-defined margins. So in one cases you have fluffy margins, in other, as it will become more and more, it appears trabeculated. It will become more compact, you can imagine. Okay, it will become trabeculated. So treatment is massage is prohibited. Limb should be rested. NSAIDs can be done. Physiotherapy can be done. Surgical excision of the bone mass can be done to regain the movement. So next you have fractures in children, which is epiphyseal injuries in children. You have Salter's Harrison classification. Salter is slipped. A is above growth plate. L is lower than growth plate. T is through the growth plate, and ER is erasure of the growth plate. Salter classification, and that is 1, 2, 3, 4. Epiphyseal slip, excellent prognosis, managed operatively. Above is also pretty good, you can manage operatively. Lower is unstable. Through is very much difficult. They are prone to limb length discrepancy, and erasure is also similar. They are prone to limb length discrepancy. So treatment, you can have non-operative treatment, which is plaster immobilization, traction, and sling. You can do all three. And operative intervention in fracture of neck of femur, lateral condyle of humerus fracture, which is type 4 epiphyseal injury, and fracture of shaft of femur. Neck fracture, operative intervention can be in a fracture of neck of femur, lateral condyle of humerus, and shaft of femur fracture. So complications, you can have growth disturbances in epiphyseal injury, brachial artery injury in supracondylar fracture of the humerus, myositis ossificans in injury around the elbow, avascular necrosis in a fracture of neck of femur. Growth disturbances can be seen. First of all, growth disturbances, brachial artery injury, myositis ossificans, avascular necrosis in fracture of neck of femur. Brachial artery injury also occurs in supracondylar fracture of the humerus. Myositis ossificans, of course, we have talked about in previously. So, facts about fracture in children. Fracture in children heals faster, close to the joint heal faster. Sideways displacement will automatically be remodeled. Rotational malalignment will never remodel. For epiphyseal injury through the growth plate, if it is, then you require operative intervention. Shaft of femur. Okay. Most common fractures, forearm fractures is most common, then supracondylar fracture of humerus, fracture of lateral condyle of humerus also. Epiphyseal injuries is common, and spiral fracture of tibial shaft is also common. Uncommon, you have dislocations are uncommon, and fracture of hand and feet are uncommon. Okay. Next we move on to peripheral nerve injuries. Individual nerve. First you have endoneurium. Nerve will be there. Above that endoneurium will be there. A bunch of nerve fibers collected to form of fasciculus, and fibrous tissue connective the fasciculus is perineurium. Number of fasciculae are bound together by a fibrous sheath which is called as epineurium. This is the structure. In this image, you kind of have to remember this. Sensory innervation of the hand, where ulnar nerve is there, where radial nerve is there, and where medial nerve is there. Ulnar nerve is the little finger, radial nerve is back of hand, medial nerve is first two digits. This image is very much important. Okay. Medial nerve, ulnar nerve. Then you have Sedan's classification of nerve injury. It can be neuropraxia. It can be neuropraxia, axonotomies, and neurotomesis. Axonotomesis, neurotomesis. So neuropraxia is physiological interruption. Anatomically they are normal. Degeneration will not be there, neuroma will not be there, and recovery in 6 weeks. Axonotomesis or axon breakdown will be there, and nerve will be intact. Nerve will be intact, but axons will be broken. It can be degeneration of proximally and distally. Neuroma will be neuroma in continuity type, and recovery will be possible or it may not be possible. Motor march will be positive. Then neurotomesis is axons as well as nerve is broken. It can be proximally or it can be distally, and it can be neuroma is at the end or at the site of the neuroma. So neuroma is at the end or at the site of the neuroma. Okay. Recovery is poor, however. So mechanism of injury, you have fracture and dislocation may be there. Direct injury will lead to cut and laceration. Infections will be lead to leprosy. Mechanical injury, you can see compression, traction, friction, and shock wear. Freezing, it can lead to frostbite. Thermal injuries may be there. Electrical injury may lead to electric shock. Ischemic injury may lead to Workman's ischemia. Toxic agents which can lead to injection tetracycline, resulting in radial nerve palsy. Radial nerve palsy can be there due to tetracycline. Radiation you can give cancer treatment. Wrist drop is a condition where the wrist remains in palmar flexion due to weakness of dorsiflexors. It is seen in radial nerve palsy. The splint you provide is cock-up splint, and treatment is treatment of motor weakness and muscle atrophy, which is Jones transfer. You have cock-up splint and Jones transfer. Foot drop is a condition where the foot remains in plantar flexion due to weakness of dorsiflexors. Both is due to weakness of dorsiflexors. But here it is seen due to radial nerve palsy. Here it is seen to common peroneal nerve palsy. The patient will have high stepping or foot drop gait. The leg is lifted more in order to get clearance. You have to lift it more to get clearance. So splint is toe raising splint. You lift the toe with the splint. Here it is cock-up splint and Jones transfer. Here it is toe raising splint and motor weakness and muscle atrophy. You do tibialis posterior tendon transfer. You do that. There is motor weakness and muscle atrophy. Then Tinel's sign, which is sign of regeneration of nerve. Gently tapping over the nerve along its course from distal to proximum, pins and needle sensation is felt in the area of skin supplied by the nerve. So radial nerve is continuation of posterior cord of brachial plexus. So you have major motor branches of the radial nerve. You have before the radial groove is a long and medial head of triceps. After the radial groove but before crossing the elbow is the lateral head of triceps, anconus, brachioradialis, extensor carpi and radialis longus. After crossing the elbow before piercing the supinator, you have external carpi, radialis brevis and the supinator. Before piercing the supinator, they will give to the supinator. After piercing the supinator, other extensor muscle of the forearm and the arm. It's kind of difficult to remember it. I'll try to make an image. First you have the radial groove. This is the radial groove. Triceps. 1, 2, 3. Triceps. Long and medial. It will supply. Okay. And then after the radial group, before the elbow joint, this is the elbow joint. It is lateral head and brachioradialis and conus. Conus, it's a very small muscle, I feel. Brachioradialis, ABR, ECRL. Okay, I'll leave it. After crossing the elbow, before the supinator. It will give to the supinator and ECRB. External carpi radialis longus, ECRB it will give. Then after the supinator and extensor muscle. Then moving on, we have radial nerve palsy. You have either high radial nerve palsy or a low radial nerve palsy. High radial nerve palsy is nerve injury in the radial groove. Paralysis of all muscles supplied by the radial nerve except triceps and anconus. If radial nerve injury is higher, it leads to paralysis of the triceps also, if it is injured in the radial groove. Low radial nerve injury, if it is injured around the elbow, distal arm muscles supplied by the radial nerve, bronchioradialis, ECRL, ECRB are spared. Okay. So before radial nerve crosses the elbow in front of the lateral condyle, it divides into two branches, superficial and deep. Superficial is before crossing elbow in front of lateral condyle. Okay, superficial is sensory, deep is motor. Travels along the side radial artery, alongside radial artery into the forearm, and deep branch supply ECRB supinator, then pierces and becomes enters the posterior compartment of forearm to become posterior interosseous nerve. They supply extensor muscles of the forearm. Then you have medial nerve, which is found by joining the branches from lateral and medial cords of the brachial plexus. Here it is posterior cord, only part which is the posterior cord. Here it is lateral and medial combined. Median. Then in the arm there is no. In the proximal 1/3, all flexor muscles of the forearm except flexor carpi ulnaris and medial half of flexor digitorum profundus. So all the muscles of the flexors of the forearm except flexor carpi ulnaris, which is the flexion of pinky finger, and flexor digitorum medial half, full medial half of the flexor digitorum, that is supplied by the ulnar. They haven't mentioned ulnar here. Damn. Okay, and then that is the proximal third. In distal third, it doesn't supply anything. In the hand, the thenar muscles, 3 of them it will supply, and the first 2 lumbricals it will supply. The 3 muscles are flexor pollicis brevis, opponens pollicis, and abductor pollicis. Adductor pollicis is not supplied by the median nerve. Note. Then high median nerve palsy, it is injury proximal to the elbow, paralysis of all muscles supplied by the median nerve in forearm and arm. Sensory deficit is seen in the skin of the hand. Low median nerve palsy, where is injury in the distal third of the forearm. You have sparing of forearm muscles. Muscles of hand will be paralyzed, and anesthesia will be present over the median nerve distribution in the hand. Then you have claw hand, which is hyperextension at metacarpophalangeal joints and flexion at proximal interphalangeal joint and distal interphalangeal joint. It is seen in paralysis of the lumbricoids. So paradoxically, clawing is more marked in lower ulnar nerve palsy than in higher ulnar nerve palsy. In higher ulnar nerve palsy, flexors of profundus and superficialis is also paralyzed. Therefore, there is no clawing. Ulnar nerve palsy leads to medial to finger developing clawing. Combined median and ulnar is 4 fingers, all 4 fingers. Treatment is Paul Brandt's multi-tailed tendon tensor. Then treatment of orthopedic disorders. General review. So osteotomy is cutting of a bone indicated in corrective excessive angulation, bowing and rotation of long bone, corrective malalignment of bone, permit elongation or shortening of bone in case of length inequality and in special indications. So you have McMurray's, Powell's, high tibial, French and spine. All of these osteotomies are present. Neck of ear is McMurray's, Powell-Wells is osteoarthritis of hip and fracture of neck of femur. High tibial osteotomy is osteoarthritis of knee. French osteotomy is correction of cubitus varus deformity. Spinal osteotomy is ankylosis spondylosis. All of this can be done. Orthodesis is fusion achieved between bones forming a joint to eliminate any motion at the joint. It is useful in painful stiff joints, unstable joints, in polio. Times you have intra-articular and extra-articular or combined. Intra-articular joint immobilized by bony union between articulating surface of the bone. Extra-articular, extracapsular bridge is created between the articulating bones. Joint immobilization by bony union between articulating surface. Bridge is extracapsular bridge between this thing, and combined is both. Triple arthrodesis, you have talocalcaneal, calcaneocuboidal, and talonavicular. All three most commonly performed arthrodesis. So bone graft, you have bone graft which can be autograft, allograft, xenograft. Autograft is free grafts and vascular grafts. In free grafts you have calculus, cortical, and corticocalculus. In vascularized grafts you have muscle pedicle grafts, free vascularized grafts. In allograft, from liver donor you have from mother, from dead body also it can be there, which is cadaveric grafts. And xenograft is bovine grafts. So autograft, vascular graft, free grafts, calculus, cortical, calculocortical, corticocalculus. Vascularized grafts, muscle pedicle graft, free vascularized grafts. Then we have tendon transfer operation. The tendon insertion of functioning muscle is moved to a new site, so the muscle henceforth has different actions. So indicated in muscle paralysis, muscle imbalance, and rupture of a tendon. So muscle paralysis, you do it to restore active control of the joint by utilizing the healthy muscle. Whichever healthy muscle is there, you use it to provide motion. And then imbalance is to restore balance between opposite groups of muscles. Then principle, you have donor tendon should be expandable, minimal power is 4 out of 5. Amplitude of exclusion should match that of the recipient method. Like how much you remove should be matched in the recipient muscle, and they should be preferably a synergistic muscle. One action they should contract. Then recipient site, range of motion of the joints on which the transferred muscle is expected to work should be good. Range of motion should be good. There should be no scarring of the bed of transfused tendon. Scarring should not be there. Technical consideration, you have transferred tendon should be ideally in a straight route. It should be placed in subcutaneous space. Okay, and fixation must be under adequate tension. Then patient considerations, minimum age should be 5 years. The disease should be non-progressive. At 5 years, the child can be trained in using transferred muscle. That's why it should be minimum at 5 years. Younger than that, they cannot be trained. Fine. So we have come to injuries, pure injuries. All of these are various types of injuries which they can ask. And okay, so I'm going to stop right over here. I'll continue after a bit. I've been on 1 hour I did right now. I'll come back and I'll finish it after some time. After maybe tomorrow I'll finish it. Okay, so yeah. Here, no. Here,